Committee for allowing me to present the take-home messages on the imaging for 2017 AUA. The most important disclosure that I have to make is that I am not a radiologist. I actually focus on MRI on the brain, specifically functional MRI in relationship to the bladder function. But first, I would like to congratulate all the authors and presenters for this imaging session at this AUA. They were all very well done studies. There were 7 hands-on and instructional courses, 2 plenary sessions, and 12 videos and 52 podiums and abstracts that I reviewed. My talk is organized by themes. Under oncology, I focused on prostate more since the majority of the abstracts were on the prostate, and I will highlight a few abstracts on the plenary session and the functional and translational urology. On the oncology side, the prostate side, looked like the majority of the abstracts were actually focused on the multiparametric MRI, and this was a study that was presented by Russell and his colleagues that looked at the value of the confirmatory biopsy for men that were on active surveillance using an MRI and fusion biopsy to predict which men might actually need to be upgraded and therefore they may need to consider a more active therapy. They did show that confirmatory fusion biopsy improves the risk of stratification as other factors highlighted here. Similarly, another study from South Korea also looked at patients, over 400 patients with Gleason score 6 who had MRI prior to their radical prostatectomy, and they looked at the upgradings and showed that the presence of PIRADS 4 and 5, along with these factors, were significant predictors of upgrading. So as important as these studies highlight the usefulness of multiparametric MRIs, there were some other abstracts that kind of made this interpretation a little bit clouded. They focused mainly on the reliability and the variability that's seen in the interpretation of the MRI, and I would like to highlight 2 of those. One of them was from Bethesda that showed that they had an unexpectedly low cancer detection rate in the PIRADS 4 lesion, and 22% cancer detection rates for cancer-specific prostate cancer in PIRADS 4 lesion. And as you can imagine, this is a pretty high false positive rate for these regions of interest on MRI. There was another study that also looked at the human component of these imaging, the interpretation that comes with the radiologist or the urologist, and this group showed that in their academic center, inter-observer agreements among the radiologists to evaluate the local extent of the disease on prostate MRI is actually pretty low. These studies kind of bring us to a pause, especially in this era that focal therapy, especially using HIFU, is becoming more attractive in treating prostate cancer. This was a group that looked at to see whether MRI is sensitive enough for partial gland treatment using high-intensity focused ultrasound, and they reported that actually a significant number of surgical specimens contained lesions larger than predicted by MRI, which that's easy to address. You can just treat a larger area. However, what was interesting is that they showed that over 60% of these pathologies had a secondary focus, which was bilateral on the other side, which makes you wonder and think about the biopsies that are needed on the contralateral side that's untreated. This imaging modality, the contrast enhanced ultrasound, is getting more attention within urology, and this group from University of Southern California suggested that maybe this could be a modality that can provide a real-time feedback intraoperatively and then postoperatively for the treated and untreated areas, so it may have a role in this field of focal therapy. There was a plenary that discussed the advances in imaging in urologic oncology led by Dr. Conetti, which discussed the trends and limitations of PET-CT in GU oncology. His panelist, Dr. Bolton, talked about the prostate-specific membrane antigen PET-CT and its restaging and its role in primary staging for high-risk disease. And Dr. Betty discussed the CUES, the contrast-enhanced ultrasound, and its indication in urology. And Dr. Desai actually summarized a very nice overview about voxel mapping and quantitative histologic imaging that can be used to help us guide us about the lesions in the kidney for clinical applications. So Q's is also getting a lot more attention in urology. As we know, this is not FDA approved, and all it's used at this point is off-label, except for the pediatric uses for vesicoureal reflux. However, because it's so easy, however, because we can use it in patients with poor renal function because of the contrast being just microbubbles, and it really doesn't have as much serious reaction as other contrast agents that we use, it's gaining much more popularity, even in the oncology field, that maybe it's being suggested that it can play a role in detecting bladder cancer tumors above 5 millimeter. So moving away from the oncology abstracts to functional urology, I found this abstract interesting from the Virginia group, that they looked at ways to use 2D and 3D ultrasound. At the same time, they were doing urodynamic testings in women with overactive bladder to be able to accurately and non-invasively measure the bladder volume. And they concluded that actually the bladder shape is not as ellipsoid as we think. And maybe using a 3D ultrasound that traces the bladder in different parameters may be a better way to evaluate that bladder shape and bladder volume. This abstract actually was an anatomy lesson for me from our interventional radiology colleagues. They looked at the data for the patients that they were undergoing prostate artery embolization, and they looked at the prostate artery origin on the CT angiogram. And they presented their data that actually majority of the prostate artery origins are from the internal pudendal artery, followed by obturator artery, and then only 1 out of 36 was from the inferior vesical artery. This is in contrary to a lot of our GU anatomy and GU textbooks that we have. So it's not only important for the prostate artery embolization, but I think it does have a lot of implications for us as surgeons as well. And for comparison, I looked up the most recent edition on Campbell, which still the inferior vesical plexus is coded as the prostate artery origin, and when you look at the reference, it's actually a reference from 1937. And I do think this highlights the need for us as urologists to be cross-informed about all these advances in other fields such as imaging, and be able to use that data and bring it back to our anatomy books and update our understanding and our information. Lastly, I would like to highlight this abstract from Baylor, Houston, that looked at, very nicely, they mastered using a micro-CT using iodine staining as a contrast to look at GU phenotyping in embryonic and adult mice. They were able to generate three-dimensional imaging, as you can see, very high resolution and contrast images to be used for murine models, as you know, that can cross the gaps between the basic science and translational science and then to clinical world. With that, I would like to thank you again for your attention, and I hope that you found this summary helpful.
Thank you.